Hey, Nikki.
Yes.
Can you hear me okay? I'm going to try without my headset today. As long as you can hear me.
Can hear you just fine.
Perfect. Thank you.
Excellent. Okay. All right. For those of you still joining, we'll give it another 30 seconds or so, and then we'll get started. Okay, my clock has turned to 2:30. So thank you for joining us for this media briefing about COVID-19 in Idaho today. My name is Nikki Forbingor, and I'll be moderating the briefing. Please note that everyone should be muted unless they are speaking. It looks like everyone is, so that's good. American Sign Language interpretation is available today. You can search for the window for interpreter stubs and hover over the three little dots to the right in the window to lock it in place. One quick planning note before we begin. After today, the schedule for these media briefings is changing to every other week. So the next one will be on May 11th. For today's briefing, we'll have remarks from several people to get us started. Health and Welfare Director Dave Jeppesen will begin, and then we'll hear briefly from Public Health Administrator Elke Shaw-Tulloch, Public Health Medical Director and State Epidemiologist Dr. Christine Hahn, and Deputy State Epidemiologist Dr. Kathryn Turner before we open it up for questions. Idaho Immunization Program Manager Sarah Leeds and Idaho Bureau of Laboratories Chief Dr. Christopher Ball also are in attendance today. With that, I will turn it over to Director Jeppesen.
Thank you, Nikki, and welcome everyone to our press briefing today. The overall state COVID-19 numbers continue to look very good. The statewide 7-day moving average of cases per 100,000 has been hovering right around 11 this week. COVID-19 testing positivity remained below 5% for the second week in a row. Hospitalizations had a downward trend last week, and however, ICU stays remained relatively flat. The number of long-term care centers with active COVID cases continues to decline and is currently at 47 out of 400 or so facilities. On the vaccine front, we just passed a significant milestone of over 1 million doses being administered in the state. And we just passed 50% of those aged 55 to 64 getting at least one shot. We continue to see a very high percentage of people getting their second dose. Of those who received their first dose of Pfizer or Moderna at least 45 days ago, only 2% have not received their second dose. However, last week we saw a further decline in the number of total doses administered, making it 2 weeks in a row where the total doses administered has declined. And we also have about 4 weeks worth of vaccine inventory in the state right now. To make it easier for Idahoans to connect with the COVID-19 vaccine provider, we have updated the covidvaccine.idaho.gov website to provide 3 ways that Idahoans can connect with the provider to get the COVID-19 vaccine. One is allowing individuals to find a walk-in clinic to get your vaccine today. 2 is information on how to contact a provider directly to get an appointment. And 3, you can still sign up for a provider to contact you to schedule an appointment. That's the sign-up system we've had for some time. In particular, we are excited that some COVID-19 vaccine providers are moving to walk-in clinics. Finally, we are removing the requirement that in order to get a vaccine in Idaho, you must live or work in Idaho. The requirement to live or work in Idaho to receive a vaccine was put in place at a time when demand in Idaho for the COVID-19 vaccine far exceeded the supply. However, our situation has changed, where supply is keeping well ahead of demand in Idaho. In addition, as some COVID-19 providers begin to switch from an appointment-based approach to a walk-in model, removing the requirement to live or work in Idaho will reduce the time needed to verify where patients work or their address and facilitate an easier process for both the provider and the patients. The removal of the requirement to live or work in Idaho is effective today. And with that, I will hand it over to Elke Shaw-Tulloch.
Great. Thank you very much, Director. And hello, everyone. And Today I'm going to be addressing a couple of items related to making it easier for providers to get vaccine to people in Idaho, as well as the new CDC guidance on masks. And the first that I'll touch on is a new grant opportunity for providers to support mobile or novel vaccine clinics. And the first part is also about unused vaccines before I get into the new CDC guidance. So today we would like to announce the availability of a new funding opportunity for providers and community partners to get vaccine into the hard to reach people and places in Idaho. The department's making $9 million available in mini grants on a first come, first served basis. Uses for the funds include, but are not limited to, holding walk-in or on-demand clinics, mobile clinics, direct service delivery for homebound or other populations, pop-up clinics, etc. They can also support the marketing, advertising, and signage for clinics or events, personnel, travel, supplies, and more as allowable by the federal funds. This is going to be a very easy to apply for funding opportunity to help provide resources to some of these more challenging and more expensive methods of vaccination. The new funding opportunity will be accessible on the coronavirus.idaho.gov site later today or tomorrow. We also wanted to address with you today the issue of unused vaccine. As COVID-19 vaccine supply is now more available, and there are opportunities to vaccinate people in Idaho, those opportunities become more sporadic. There's also a greater chance, that vaccine may go unused, both unintentionally and intentionally. For example, a large appointment-based clinic may be scheduled and wind up with no-shows or cancellation after vaccine has been drawn from vials or vials that have been held out at room temperature, leaving those unused vaccines to be wasted. Another example is a practice getting a walk-in or late in the day patient, posing an opportunity to vaccinate a person, but a new vial needs to be opened for only that one person or very few people, leaving the provider to decide if they should vaccinate while they have the chance and waste the vaccine, or let the patient leave without a vaccine if they want it. We're hearing from providers that they're experiencing these scenarios and are requesting guidance on how to address those issues. So to address this, last week we issued guidance to enrolled Idaho COVID-19 vaccine providers, emphasizing that while we are concerned about not wasting vaccine when possible, we also want them to prioritize vaccinating people over holding off due to concerns about wasting vaccine. We feel it's more critical that providers ensure people who want to be vaccinated are able to get the vaccine. So in summary, our guidance on unused vaccine, as well as our provider mini grants to support mobile and novel clinics, we hope will help assist providers get more vaccine out into the public. Last thing I want to address today is the new CDC guidance on wearing masks outdoors for people. So as you know, it's been all over the news this morning that CDC announced updated guidance on wearing masks outdoors. Their new recommendations state that fully vaccinated people no longer need to wear a mask while outdoors unless they're in a crowd of strangers, like an outdoor concert or sporting events. People are considered fully vaccinated, as a reminder, approximately 2 weeks after they receive their second dose in the 2-dose series, or approximately 2 weeks after a single dose vaccine. Outdoor activities where fully vaccinated people do not need a mask include walking, running, hiking, and biking, for example, with members of the same household, small outdoor gatherings with fully vaccinated family and friends, and even a mixture of fully vaccinated and unvaccinated people, as well as outdoor dining at a restaurant. CDC does continue to emphasize the wearing of masks indoors in public spaces. While we continue to review this new guidance, there are also 2 more notable changes that they announced. One of them is that fully vaccinated residents of non-healthcare congregate settings no longer need to quarantine following a known exposure. So that might be a scenario like a university dorm. The second point is that fully vaccinated asymptomatic people without an exposure may be exempted from routine screening if feasible. So those are both scenarios if a person is fully vaccinated. So with that, I'm going to turn it over to Dr. Hahn.
Can you hear me okay?
Yes.
Thank you. So I just want to make sure everyone is caught up on, I think you're all aware that last Friday CDC and FDA issued that recommendation that use of the Johnson & Johnson vaccine could resume. The decision came after a lengthy safety review and recommendations from the CDC's Advisory Committee on Immunization Practices. So of course, we're all very happy to hear that we have this tool. The vaccine's been very well accepted by providers and by patients because of the convenience with a single dose, the lack of need for freezer, and really most people have very mild or no side effects. So it had been going very well until these very rare but very serious adverse events were reported. So despite the good news that it's back, we want to emphasize three things. We think it's important that everyone is aware of these rare but serious side effects, and the measures that we're recommending are, first, each community should work to ensure that multiple vaccines are available in their community, and this is really our public health working together with healthcare providers in the community to ensure that there are choices available locally, that people don't have to travel extensively to get the vaccine they want. So at least 2 of the vaccines, ideally, would be 3. I'm fortunate enough to reside in Boise area where there are lots of vaccines available and people have the choice. I understand it's more challenging in more rural communities, but choice is important. One example, for example, is that a 16 or 17-year-old can only get the Pfizer vaccine right now. That's the only vaccine authorized in that age group. So communities should work to ensure that Pfizer vaccine is available for parents that are looking for that vaccine for their children. Next, it's really important that patients are able to actually know where to get the vaccine they want. So, for example, pharmacies, clinics, and vaccine providers should make sure that they're transparent about which vaccines they have. That could be making sure it's on their web page, making sure that there's signage at the location, and really importantly, we are requesting all providers to put that information into a vaccine finder, which is at vaccinefinder.org, all one word, Vaccine Finder, a very robust website in which you can find any patient seeking vaccine can find any vaccine providers in their area, and you can select for whatever vaccine you're interested in, or all 3 if you're interested in any of them, and you can select for 5 miles, 10 miles, 25 miles. So depending on how far a patient is willing to travel, it will show vaccines available in the area. A very robust tool. I spent some more time on it this morning and put in about 50 of our zip codes around the state to see how well it worked. And I was very impressed. For most Idahoans, they will find a selection in their area and they'll be able to see which vaccines are available. Lastly, safety is the top priority of this immunization effort. After all, we're vaccinating to protect people from a serious disease. And we want to make sure that patients that are choosing to get vaccinated are safe and are confident that they will be safe. So we are urging providers and also patients to make sure that they're aware of the side effects and potential risks of any of those three vaccines. The FDA has updated all their website information. There are handouts that need to be given to patients that should be reviewed carefully. And if a patient says, well, wait a minute, I'm not sure that that's the one I want, then I'm worried about, let's say it's Pfizer, that allergic reaction, or I'm worried about the blood clots, that the patient is informed how they can go seek other vaccine, whether it's Vaccine Finder or whether it's through knowledge of what's available in that community. So while we're very excited to see this vaccine return and be used in Idaho, and we've had no problems here identified, we want to make sure that people are given true choice about which vaccine they get to the best of our ability. So with that, I'm going to turn things over to Dr. Turner.
Thanks, Dr. Hahn. Good afternoon, everyone. I am going to provide some brief updates on Idaho cases identified as infected with variants of the virus that causes COVID-19 that are of interest or concern to public health, as well as COVID-19 vaccine breakthrough cases. So we currently have 215 COVID-19 cases reported that we have confirmed are infected with a virus variant of public health concern or public health interest. And these infections have been confirmed among residents who are living in 17 counties in Idaho. Of those, 75% were identified as the B1617 variant. This is the variant that was first identified in the UK. And 20% were identified as the B1427 or 429 variant. And this one is the one that was first identified in California. We also have 2 infections confirmed to be with the B1351 variant, and this has not changed since for a few weeks now. This is the variant that was first identified in South Africa. And this week, just wanted to let you know, 3 people have been identified as being infected with the variant that was first identified in New York, and this is the B1526 variant. We are also working with Central District Health to verify a report of an infection with the P1 variant. This was first identified in Brazil. If we do verify this, it would be the first infection with that variant identified in Idaho. So more to come on that investigation. People infected with virus variants of public health concern or interest tend to report being symptomatic more often when we compare them with all of our other cases. But both the hospitalization rate and the death rate among people infected with variants appears to be comparable to rates that we see among those who are not infected with the variants. However, I do want to note that we have so few cases, we're just a little over 200, that we can't draw definitive conclusions, and we'll continue to keep you updated on what we know about these cases as more and more are identified. In addition, Idaho's data are not necessarily generalizable because samples are prioritized for sequencing with a bias towards finding variants. But as for the whole genome sequence, as the capacity for whole genome sequencing increases and more specimens are sequenced, we may be able to better generalize about the prevalence of these variants that are circulating in Idaho. I do want to take a second to mention that we are also watching the B1617 variant. This is the variant of interest, the World Health Organization variant of interest that was first detected in India last winter. And it has been detected in the US and at least 18 other countries and territories. So while the current surge of cases in India is likely a result of many things, during March, the percent of samples in India that were identified as this particular variant increased from 16% to 70%. And it isn't unreasonable to speculate that this variant may be contributing to that surge in cases right now in India. We do know that there have been at least 20 cases of this infected with this variant identified in California in the US. So with that, I'm going to pivot a little bit and provide a quick update on vaccine breakthrough cases. You all know that vaccine breakthrough cases are not unexpected because I say that every single press briefing that we have. COVID-19 vaccines are effective, but none are 100% effective at preventing all illness. Therefore, we do expect a small percentage of people who are fully vaccinated might get sick, might be hospitalized, or even die from COVID-19. I also want to remind you that we post the number of vaccine breakthrough cases on our data dashboard, and we update that case count every weekday by 5 p.m. So today we'll be reporting 190 vaccine breakthrough cases in Idaho. This does represent less than 0.5% of people who are fully vaccinated. Infections with the virus in people who are fully vaccinated have been reported among people from 18 to over 100 years of age, and the average age of vaccine breakthrough cases is 58 years. Just over 40% report no symptoms, and of the 60% with symptoms, 94 report mild or moderate symptoms ranging from cold-like to flu-like symptoms. Just like last week, 4 people, or roughly 2% of the cases, have been hospitalized because of their illness, and each of these folks were at high risk for severe disease. However, I am saddened to report that 1 person with a vaccine breakthrough infection has died in the last week, and so it's just a reminder of how bad COVID-19 infection can be in the population. Regarding genetic sequencing, 7 samples have been identified as a variant of public health concern, 4 with the B1427 429, or that variant identified in California, and 3 with the B117, or the variant that was first identified in the UK. And just a reminder that current COVID-19 vaccine recommendations are that everyone should receive a vaccine unless there's a contraindication to receive the vaccine or you're not eligible for the vaccine based on age. And with that, I'll turn it back over to Nikki Forbing-Orr.
All right, thank you, Dr. Turner. So we will now take questions from the media participants. We will answer as many questions as possible in the time we have available today. I'm seeing some hands go up, so that's good. Please raise your hand in WebEx by selecting the hand icon in the lower right part of your screen. And you can also type your question into the chat area, which you can also access in the lower right part of your screen. When I say your name, please unmute yourself and announce your name and media outlet before asking your question. And please remember to clear your hand when you are done. All right, I'm going to start here with Kyle Fonensteel.
Thanks. This is Kyle Fonensteel with the Post-Register. I wanted to ask, it's been 4 months since healthcare workers first started accessing the vaccine. I guess a two-part question is, I'm wondering, what are you seeing in vaccine uptake among hospital workers, and how is this affecting their staffing, their sick time, and any outbreaks in their facilities?
That's a great question, Kyle. And since we have Sarah Leeds on the phone, who runs the immunization program and works with those providers quite frequently, I'm going to turn it over to her.
Thanks, Elke. Unfortunately, I don't have any hard information about the numbers of healthcare providers getting vaccinated now because, as we've said in the past, Idaho's Immunization Information System, or we also call it IRIS, does not collect occupation. So now we have so many folks vaccinated, we don't know what occupation they are. So the information that we do have is anecdotal. And so what we are hearing are that, of course, we had a lot of folks from the healthcare industry and those frontline healthcare workers getting vaccinated early. And then we do know that there were people who were hesitant at first among those frontline healthcare workers, and that as time went on and they were seeing their coworkers get vaccinated and not have have minimal side effects and seeing the safety of the vaccine, they were deciding to get vaccinated. And so we do know that it is growing, and continues to grow. So, and that's really probably as far as I can go to speak to that at this point in time.
Thanks. Do you know about how this might have affected exposures and outbreaks within facilities?
Go ahead, Sarah.
Do you want me to answer?
Oh, sure, Director, go ahead.
Okay, thank you, Elke. Thank you, Kyle. Excellent question. Again, this would go in we don't have an active data reporting on the question you've asked specifically, but in my conversations with healthcare providers, they have seen less people out due to being ill or exposed to COVID-19. And so while there still are some cases of COVID-19 among the healthcare workers, that's been greatly reduced and has actually increased their ability to staff. In addition, as you heard Elke mention a minute ago, for somebody who's been fully vaccinated, if they've been exposed for a while now, they've been able to not have to quarantine if they're not symptomatic. And that actually has greatly increased the ability of healthcare workers to continue to work, even if they've been exposed but fully vaccinated. And so generally speaking, the impact that COVID had on staffing at healthcare providers has gotten considerably better over the past couple of months. And unfortunately, we don't track exact numbers on that, but that's what I hear when we talk to healthcare providers.
Okay, we'll go to our next question, and that's going to come from Hyatt Noramina.
Hi, Hyatt Noramina from the Idaho Statesman. Thanks, Nikki. I just had a question related to the proof of residency requirement that's lifted today. Are you replacing that with any other requirements, like U.S. citizenship or anything like that? Is a passport permitted to get the COVID-19 vaccine?
Thanks, Director. Do you want to take that?
Yeah, the short answer is there's no restriction on who can get vaccinated is the short answer. So anybody that resides in the state and that or is visiting the state or is here and happens to want to get vaccinated, there's no restriction on them having access to the vaccine.
And just a quick follow-up, are you hoping to get more of the border residents first? Is there any sort of strategy around that?
Okay, I'll take.
Go ahead.
Sorry.
Me too, as the follow-up, pardon me.
Thank you. Hi, excellent question. Our main strategy is not necessarily to entice border residents to come to Idaho to get vaccinated. Certainly, if they want to, they're welcome to do that. Our main motivation is primarily to remove barriers between providers and patients in Idaho, frankly, to get vaccinated. And so as we move to a situation where we have more supply than demand, and if there's even a little barrier that says I've got to show I work here or live here, that may be enough for somebody that's very busy to decide it's just not worth my time right now. And so our main motivation is to just remove as many barriers as possible so that it is as convenient and easy as possible for individuals to get vaccinated. And that's particularly true for the clinics that are moving to walk-in, where we want that to be, you know, I'm at my grocery store and the pharmacy has a sign that has to have a vaccine, and I just want to make it as easy as possible that I can go to that pharmacy and ask for a vaccine and get one.
Thank you. Just another quick follow-up. Did you have undocumented workers in mind for that? For example, that's just one population that comes to mind that may not have a driver's license.
Yes, we had that in mind even when the policy was in place, because if they live here, we want to get them vaccinated for all the reasons that all of us should get vaccinated, or I should say we want them to choose to get vaccinated. And so even when the policy was in place for an undocumented worker, they still had other avenues to show that they lived here, whether that was a letter from a church or an employer or other ways to show that. But certainly we hope that this will make it even easier for all populations, including undocumented, to get access to the vaccine.
Okay, our next question is going to come from Selena Van Heining.
Hi, everyone. So this might be a question for Dr. Turner or Dr. Hahn. It has to do with breakthrough cases in females. So last week, Dr. Turner, I believe it was you who said that 90% of all breakthrough cases in the state were found in females, which is pretty high compared to 65% of females who are identified as a breakthrough case nationally. And also of that number of breakthrough cases, I believe a pretty small percentage received the Johnson & Johnson vaccine. So with this information, is there any concern about how the vaccines may affect females differently than males?
Why don't we want to start with Dr. Turner and then Dr. Hahn, you can step in, or either you.
Yeah, thanks, Elke. I think I'm going to defer to Dr. Hahn on that one.
Okay.
Sorry, Dr. Turner, I assumed it was for you, so I think I phased out the very end of the question. I know it was about that we were reporting more breakthrough cases in females. And then, but the actual question was whether the vaccine works differently in females than males.
Yeah, it was,
right?
Yeah, just is there any concern about how the vaccines may affect females differently than males? Because it seems in Idaho that females tend to be identified as breakthrough cases more than males.
Right, thank you, yeah. I wasn't quite sure I had it right, but that's, thank you. Yeah, so a couple things. First of all, we definitely know that that immunology is very different between females and males. And really the best COVID-related example of that has been what's happened with Johnson & Johnson vaccine, where of those 15 cases with a severe clotting problem, and again, we know this won't stay this way. I saw in the media yesterday that there is a male that's being reported by a university medical center, but the first 15 cases that were reported were all in females. And there's speculation that maybe something hormonal is different, especially as women in their 30s seem to be kind of at the highest risk in that group. Maybe there's something hormonal going on that's different, and it's not understood. It's being studied. So certainly vaccines do affect men and women differently, as do many other medications and treatments and so forth. However, we don't have any evidence yet that I've seen that the vaccine fails more frequently in females. What we don't know, and I'll let Dr. Turner chime in if she has more information than I do, but what I suspect what we don't know is, we know that women in general tend to be more healthcare seeking, right? With the same level of symptoms, females are more likely to go in and I'm going to get that checked out or whatever. So it is possible that in some of these cases, it is a bias of women appearing for care, whereas it maybe a male, hey, I'm vaccinated, I'm sure it's not COVID, maybe wouldn't have gotten tested or evaluated. However, that's all speculation. We really don't know. But to your main question, I think we absolutely know that the vaccines do affect men and women differently, and we're going to find out more about that over time as we see how well the vaccine works in populations.
Thank you. And just, I'm sorry.
Go ahead, Selena.
I just had a quick follow-up, unless Dr. Turner, did you have anything to add to that? I'm sorry.
Yeah, I think the only thing that I will add is that for our next press briefing, or maybe after this one, what we can do is look at one of the things that we don't display on our dashboard is the vaccinations by sex. So we can look at that data. I can tell you from what I've looked at that we do have a tendency to vaccinate more females. So it would make sense that our breakthrough cases might be more frequent in females, but we'll look at that a little bit closer and follow up.
Thank you. And then just a quick follow-up. I know that nationwide and also here in Idaho, there's been some vaccine hesitancy. Did you see an increase in the vaccine hesitancy last week following the Johnson & Johnson pause, or has it just kind of stayed the same?
Yeah, I can go ahead and take that. Yes, we did definitely see a drop off, and last week I did show that in the graphic form where you could see the decline in the vaccine uptake, and then we've seen even a further decrease this most recent week, and not just in the Johnson & Johnson, which of course we expected because there were no doses of that vaccine out in the streets, so to speak. But we also did see a decrease in the Pfizer and Moderna vaccines as well. So there were some hesitancy issues, some wait and see. Again, anecdotal information from what we're hearing from the providers, but definitely a drop off.
Thank you.
Mm-hmm.
Okay, our next question is going to come from Audrey Dutton.
Hi, Audrey Dutton from the Idaho Capital Sun. You'll have to forgive me if a toddler starts screaming or the people cutting trees next door start cutting the tree. It's been a wild day. So I am looking at the HHS vaccine hesitancy data. So they put together earlier this month a map by county of vaccine hesitancy estimates. And for example, there was 27.55% in Elmore County, with 13.35% as strongly hesitant. And now Elmore, of course, is one of the hot spots. So I'm wondering, how does the vaccine confidence plan take into account geographic areas? Is that something that you're trying to target? Do you have your kind of eyes on uptake numbers by county, anything like that?
Yeah, Audrey, absolutely. We're looking at all of that. We're looking at counties with high social vulnerability index. We're looking at counties that have higher hesitancy rates. That's one of the reasons why we're doing everything we can to help support providers to get vaccine to people, and then on the other side of that, to support people getting to the vaccine. So trying to, as the director had said multiple times, and I also said, we want to eliminate all the barriers we can. And then we also want to zero the vaccine in on where there's both the greatest need and not just the vaccine, but also those opportunities for education, conversation, that we have places where people can go to ask questions about the vaccine. And it's going to look different for different populations and different areas of the state. But those are some of the things that we're trying to address through the local public health districts and other partners.
And Dr. Hahn, is the goal still 80% by September?
We are really, I think where we're really shooting for is well, I'll put it two ways. One is herd immunity. Right now, the best estimates out there are that is about 80%. And so we are, I think, using it, I'll call it a working number for us. So we have something to aim towards, is 80% right now, because it seems like that will achieve where we really want to be by next fall when school opens. And as we talked about, I think last time, we do recognize that seniors are a lot closer to that than our younger populations. And so we are focused on seniors for short term, trying to really push them closer to that target. And then we will turn our attention to younger folks. I think you asked the question, Audrey, last time about 16 and 17-year-olds, and we did look at that data as well. We've started looking at that. As I talked about earlier, we know that the Pfizer vaccine is their only option right now. So we are also talking about how to make sure we have Pfizer available everywhere, and looking at, and as the vaccine gets available to younger populations, which we think will happen maybe mid-May, if Pfizer's application gets approved, we really need to start looking at how to work with pediatricians and other folks that take care of children and parents.
Okay. Oh, sorry, Audrey. So I'm going to read a question now from the chat. This is coming from Karen Bosick from Ion Sun Valley. And her question is, do you have any sense how many Idahoans who might have wanted the Janssen or the Johnson & Johnson vaccine are afraid to get it since the pause?
That is a really, really challenging question to answer. So you don't know what you don't know, I think, is the hardest part. But we do know that, in some, well, first, the vaccine clinics were canceled. So we do know that there were clinics set up and appointments made available. So we know at least the number of Janssen vaccines that weren't administered. But how many people are reluctant to go now? That's hard to tell. So I'm going to see if Sarah has any additional information to support the number side of that. But the bottom line is it's hard to know what you don't know, and we're doing everything we can to make sure that we have opportunities to reassure people that the Janssen vaccine is still a great option. But as Dr. Hahn had said as well, we want to make sure that there's also, opportunities for people to make that decision about which vaccine they want.
Yeah, thanks, Elke. I unfortunately, I don't have any numbers, but we have been hearing kind of both sides of that. Some of the providers are saying, we really had plans for vaccinating with Janssen. We will start it up as soon as we get the go ahead, and then we can assume that there are folks who are now hesitant because of the pause, and so we know they're out there. I have not heard that specifically from providers, but those might be the people we don't necessarily hear from. They just don't show up. So, I think one of the things we'll be doing is looking at stronger education around the vaccine, in particular, and also both types of vaccine, both the messenger RNA and the adenovirus vector and the vector virus.
Okay, thanks, Sarah. Our next question is going to come from Ian Stevenson.
Hi, thank you. This is Ian. I'm from the Idaho Statesman. So based on the decrease in vaccine uptake, and Dr. Hahn touched on this a little bit, but do you all expect that we will reach herd immunity in Idaho? And if not, how might this affect potential for future outbreaks or spikes in the state, and also future public health requirements for the general population and the state's efforts to reopen?
That's a big question, Ian. I'm going to turn it over to Dr. Hahn to talk about the herd immunity piece.
Yeah, sure. Thank you, Ian. You're thinking ahead. I like that. It's really important, and we do talk about this a lot. We know that we will not be able to reach true population herd immunity soon because there is no vaccine right now for anyone under 16. So it's not even a theoretical possibility if we had all the resources in the world. So for right now, we're focusing on the populations for which there is vaccine. But I think we're a little bit beholden to when these vaccines get authorized for younger populations. So that's why I think for now, when we talk about targets, we are really going to focus on different age populations among adults and not overall population immunity at this point. We just don't have the vaccines for that yet.
Thank you. Thank you.
Okay, our next question is going to come from Rachel Cohen.
Hi, this is Rachel from Boise State Public Radio. I have a couple questions about the grant funding opportunity. My first question is, who can apply for that? Do you have to be an enrolled provider, or can it be nonprofit organizations?
Thanks, Rachel. We do want to make it available to community partners as well as enrolled providers. But if a community partner, let's say a church, were interested in doing something like this, they would have to partner with an enrolled provider, because the enrolled provider is how they would be able to receive and administer the vaccine.
Okay, thank you.
Mm-hmm.
And my next question is whether there are any groups, whether it's geographic regions or age categories, where the state would like to see some providers sign up to try to reach populations that maybe have some access barriers currently. Are there any examples that you can give of places where there could be some increased access?
Certainly, I think there are probably a lot of examples. I'll give a few. We know that there are homebound populations across the state. There are certain providers that are very interested in making that their business model, if you will, of addressing homebound individuals. For example, using that kind of Meals on Wheels model to get vaccine into those households. There are providers that are interested in working specifically with, specifically with some of our business partners or private providers across the state that might have a larger Hispanic population in their workforce, that they want to host a specific type of vaccine clinic for those providers. Also working, for example, with churches across in different areas of the state, where we know that there might be harder to reach populations. So I know that in some cases there are providers that are partnering with churches to look at holding a vaccine clinic immediately after Spanish-speaking Mass, and trying to get the Hispanic population as they are right there on location. So there are a lot of different types of models that different providers are interested in doing across the state. So we want to be able to, if a provider also needs support on some data, where we might have counties and geographic areas with higher social vulnerability indexes, we were happy to help provide some of that information and direction to help get them into those areas. And as they work also, of course, with their local public health districts on getting that vaccine distributed to them as a local provider, those districts also have access to a lot of data to help them make those decisions and drive that business.
Okay, thanks, Elke.
Mm-hmm.
Our next question is going to come from, it'll be another question from Ian Stevenson at the Statesman.
Sorry, I didn't mean to raise my hand again.
All right, then I have another question from Karen Bosick from Ion Sun Valley in the chat. She wants to know if the department knows how many Idaho veterans have gotten vaccinated or plan to get vaccinated, and if the percentage is low, how the department might address that.
That is a great question. And Sarah, I'm going to turn it to you to see if you have that information.
Elke, I do not have that information right at my fingertips right now, but we could go into Tiberius and see what the Veterans Administration has vaccinated and give those numbers. We don't have a comprehensive number of veterans if they got vaccinated outside of that federal program. but we could give some numbers.
Thank you.
Okay, we'll go next to Hyatt from the Statesman.
Hi, I just had a couple quick follow-ups. So, do you have a timeline? Have you heard anything about the Pfizer vaccine, which recently asked the FDA for approval for 12 to 15-year-olds, whether you've heard anything on that front? And then my second question was just about the grant funding, where that's coming from. Does that come from federal funding?
Yeah, I will. Thanks, Hyatt. You have the two-part question. I'll answer the second half of it and then turn the first half about the EUA for 12 to 15-year-olds to Dr. Hahn or Sarah. Regarding the federal funding, it is for the mini grants. Yes, it is federal funding. It's coming through the federal funds that support the vaccine program or immunization program that Sarah Leeds directs. And then the second part, Sarah or Dr. Hahn want to address the EUA for 12 to 15-year-olds.
Yeah, I'll mention, I just heard this yesterday on a CDC call, so I feel pretty up to date, but they say right now the best estimates are mid-May. The way to know for sure is, and I check every once in a while, the FDA's website. They announce all their advisory committee meets. When that schedule goes out, you know that's the day that they're going to discuss that authorization, and I haven't seen it yet, but I kind of keep my eye on that. So mid-May is the estimate. I have a 15-year-old son, so I'm very invested in this, and I'm going to keep checking. But this would be for 12 to 15-year-olds, as I think you know. So that would be a really exciting development if that got authorized.
Thank you.
Mm-hmm. Okay, and our next question is going to come from second question from Kyle, the Post-Register.
Thanks. Earlier, you talked about trying to reduce vaccine waste by encouraging providers to get vaccines in arms no matter what. I'm wondering if the state is exploring the possibility of shipping doses to other states if demand declines more.
Yeah, thanks, Kyle. I know that definitely is something that we've been talking about on a national level through our state health official conversations and through HHS. And I'm going to see if Sarah Leeds has any more recent information that's been talked about at the programmatic level.
Thanks, Elke. We've just went with our calls one-on-one with CDC. There's just been some like, what would that look like if that were to happen? And so there's been nothing that we've talked about that would be anytime very soon or anything more concrete with more of a planful nature. So it's a possibility in the future, and it's just something that we continue to talk about.
Okay, it looks like our last question is going to come out of the chat. It's one more question from Karen with Ion Sun Valley. She says that she has heard from people who have epilepsy who say the vaccines could be dangerous for people who have epilepsy, but she's never read anything to that effect, and she wonders if that is a myth, or if there is some validity to that.
Okay, thank you, Dr. Hahn. Do you want to take that?
Yeah, sure. I will tell you that with the 3 vaccines that are authorized in the United States right now, none of them have epilepsy, as a concern. I think where that might come from, I am speculating at this point, but we know that some vaccines, especially vaccines given to small children, can sometimes cause a fever and occasionally even a febrile seizure if the fever gets really high. So there are some concerns in small children sometimes about a seizure after a really high fever. But I have not heard of that being reported with the currently authorized COVID vaccines. Of course, anyone with epilepsy, I totally understand them being particularly careful about their health and not wanting to risk it. And I would certainly say if they had any questions, they could talk to their provider, that might be able to steer them towards one or the other of the vaccines.
All right, I am not seeing any more raised hands in the WebEx, and there's no more questions in the chat, so we're going to wrap it up for today. We are planning another media briefing at 2:30 p.m. Mountain Time on Tuesday, May 11th, which, as I mentioned at the beginning, is 2 weeks from today. You can watch for those details on Monday, May 10th, and thank you all very much for joining us today.